Well, hi, everybody. Welcome to today's webinar. It's part of the KaiNexus Continuous Improvement webinar series. I'm Mark Raven. I'm your host and moderator today, and I'm really excited about today's session. It's titled Person-Centered Improvement. What does it look like, and how does it fit with Lean? Presented by Paul Teeling, and I'll tell you more about him, more formally introduce Paul in a minute. But first, just a few announcements about the logistics and being an engaged, interactive attendee in the webinar today. If this is your first time attending one of our webinars, we want to invite you to come check out our website, KaiNexus.com, and learn about our KaiNexus continuous improvement software platform, the problems we solve and the solutions we offer. Again, you can go to KaiNexus.com. Final announcement here. Again, we're asking people to help share about the webinars on LinkedIn. You can do so for future webinars. If you post or repost something about the webinar and use the hashtag KaiNexus, as you see pictured below on a previous webinar, we do book giveaway contests. And this webinar, we are again offering 3 signed copies of my new book, The Mistakes That Make Us. And today's 3 winners will contact you by email are Carrie Walton, Kirsten Farmer, and Roberto Flor. So thanks to everybody who helped spread the word about the webinar, and we hope you'll continue doing so in the future. So now, before handing over to Paul for his presentation, let me go ahead and formally introduce him a little bit. I am incredibly happy that Paul is here with us today, presenting in our webinar series. I've had many invitations that I've been able to accept from Paul to give presentations for his classes in Ireland. So I'm really happy that now Paul is in the presenter seat today, and that we could bring him to you. I've had 2 opportunities to come actually visit the health system, a couple of hospitals, and Paul's classes in Dublin. And I know he has a lot to share and teach us all today, regardless of our industry, healthcare or otherwise. So Paul Teeling is the program director for the Professional Certificate and Graduate Certificate in Process Improvement in Health Systems at UCD Health Systems. Prior to this, he worked as a lean manager at a university hospital in Dublin, working closely with the hospital and the UCD School of Nursing, Midwifery, and Health Systems on the development of the highly successful process improvement in healthcare programs. Paul is an accredited facilitator of person-centered cultures in healthcare. He has a PhD and is a member of and honorary lecturer with the Center for Person-Centered Practice at Queen Margaret University in Edinburgh. His research is in the use of process and quality improvement methodologies in healthcare, including the model for improvement, Lean Six Sigma, and Agile, and in particular, the influence and contribution of process improvement methodologies on person-centered cultures, as we're going to learn about today. So again, really pleased to hand things over to our presenter and my friend, Paul Teeling.
Thanks very much, Mark, and thank you everybody for coming. And I hope you'll find something useful in this session. And it's usually Mark, as he said, in the presenting seat, so role reversal. But nice to be here, and thank you. So again, as Mark said, this is really talking about person-centered improvement. What does it look like, and how does it fit with Lean? I suppose just to give you a bit of background, my background is in nursing, midwifery and health systems, and pediatric nursing. I worked as a project manager, but I spent most of my career in OR nursing, operating room nursing, predominantly in transplant programs in the States and the UK, United Kingdom and Ireland. And then I was the project manager for a major hospital in Ireland, the clinical project manager. And it was when we were building the new hospital, I suppose about 13, 14 years ago, we realized that as the hospital was nearing completion, we were missing one thing. We were looking at the structures and the systems, but we weren't looking at the processes. So we realized quite quickly that if we moved to a new campus, but we were doing things the exact way we did them currently, that actually we would actually see no improvement, or the services actually wouldn't be that much better, despite a brand spanking new building. So that was sort of where my interest began in Lean and trying to understand it. So as Mark said, I am from a healthcare background, but I have worked in project management and in different jobs and roles as well. So hopefully some of what I'm sharing today will be of relevance to you and be of some interest. So hopefully at the end of today, as Mark said, the idea would be that you'd understand what we mean by person-centered improvement as opposed to client-centered or human-centered, and where they're similar as well. Identify the synergies between lean and person-centered improvement, and to an extent Six Sigma as well. Understand where the person-centered improvement diverges from lean and how we might be able to address it, and then how you could incorporate this approach into your work. Quite easily, if I'm honest, it wouldn't take much, but just to be able to integrate that into your work as well. So I suppose to start off, let's talk about the complexity of healthcare. And Drucker described healthcare, as many of you know, as the most complex of any industry. And he said that this was complex because of the confluence of all the clinicians and all of the various players involved in healthcare, whether it was nurses or doctors or health and social care professions or the administrative and support roles, and all of our other stakeholders, myriad stakeholders involved in healthcare. And often, he said, with seemingly incompatible perspectives and competing timelines and different needs, obviously. And one of the biggest healthcare challenges today continues to be equitable and timely and fair access to care. And I can speak about this internationally, obviously not just in an Irish context. And many countries are struggling with disparity in access to healthcare based on factors like income and location and ethnicity and gender, leading to inequalities in experiences of care and to obviously having an impact on people's health outcomes as well. And meanwhile, in this context, another context, I suppose, to add to that is the continuing rise of healthcare costs internationally, making it difficult for some people to access that care in the first place, to afford that care. And this can again result in delayed or inadequate treatment. And another big factor would be the demographic shift. We have an aging population, which poses challenges to the health service because there's more dependency on the service as well. And this will include people are living longer. So, to include things like long-term management of chronic conditions. And this is putting the healthcare system under further strain as well. So there's a huge strain on the system, and this is the system in which we work. And more recently, as you'll all unfortunately remember, the COVID pandemic and indeed influenza every year have been shown to be able to overwhelm the system quite easily and to put more strain on resources. And post-COVID and in the current situation, and even before that, many of you who work in healthcare will know one of our big problems is getting skilled workers. So we've shortages of healthcare professionals, including doctors and allied health professions and nurses, and that can limit our capacity to deliver top quality and timely care. On top of that, we have technological advances, which are great, like telehealth and telemedicine and artificial intelligence. But again, staff are hard pressed at the moment due to shortages and working in very complex systems and capacity and demand issues. And learning any of these new systems in itself can be extra work. So although they're beneficial, all the new technologies, they also have a learning curve for staff as well. And these challenges are varying across different countries and regions and require very context-specific solutions and strategies. And for example, a recent study showed that post-COVID, 28.4 million surgeries were postponed or cancelled during COVID. And the system, which was already under pressure, is trying to cope with that. So that's the type of complexity that Drucker refers to, the complexity of a system that is, and we all know patients get good care and good customer services delivered, but it can be difficult with those variables all at play. I suppose a more day-to-day example of the complexity of healthcare would be something like a hip fracture. So let's say Betty, who's 83 years old, falls and fractures her hip. And she enters an acute hospital, and she's seen by the registration staff, and then they triage by the registered nurses, and she's seen by the emergency team, and she has her diagnostics, and she's seen by the orthopedic team, and then she's supported by the nursing and support teams in the ER, and then she's off to the OR and the various teams there, and then she's getting a lot of physio and occupational therapy post-surgery. And then there's all of the services that we don't really talk about that are considered back of house, like who gives her dinner, who makes sure she's fed, who makes sure her room is clean. And then it's off back to the community where she needs occupational therapy assistance, some adjustments to her house. So in Betty's journey, And I mapped this out because unfortunately Betty's passed away now, but she was my mother. So I process mapped this in detail. There was 118 people touched her care. And that was in a level 4 trauma center. So that day, 67, 68 other patients went through that pathway. So that's the volume and the complexity of what we deal with. So that's what we're trying to deal with. So in trying to deal with this complexity, we're introducing, and now I know they've been in healthcare since the noughties, but we're introducing methodologies the whole time to try and cope, not just Lean and Six Sigma and person-centeredness. You've got your Prince 2, you've got your model for improvement. Sometimes I feel staff will try anything that will make something work. So in 2013, I read a paper that contended that Lean, in particular, Lean methodology does not support person-centered care. And it said it's all about standardization, that organizations need to produce efficiencies. Now, as a Lean practitioner, but also a person-centered practitioner, really, I'll be honest with you, as we say in Ireland, it got my back up. I thought it was a very broad statement. It was very limited, very short overview of Lean, showed very little understanding, I felt, of the methodology. And when I did a review of the literature then at that point, and so I'll do a quick review of the literature and see what's out there, actually, there was very little there to support, to reject that hypothesis from that author. I was going, well, actually, there's nothing there to say that Lean is person-centered. Although I may think it as a practitioner, there's actually no empirical evidence to support this. And in those complexities that I just spoke about, we're using more and more improved methodologies, and Lean and Six Sigma are some of the most popular, as you know, internationally. But I knew that Lean was formed on, the whole concept of valuing the person and the customer, and that it was about designing the service around their needs. And that was something that was, really important within healthcare design and redesign. But however, whilst there was a lot of literature and a lot of research talking about how effective Lean and Six Sigma were and their impacts and efficiency, there was absolutely nothing really out there talking about how it related to person-centered care, how they could be used in tandem or couldn't be used, and what their contribution would be to a person-centered culture. So that sort of kicked off a research piece over 5 years with the Person-Centered Practice Research Centre in Edinburgh, with UCD Dublin, University College Dublin. So it was between those two universities, and between the Mater Misericordia University Hospital, which was one of our study sites, and then between 10 further sites in the last number of years, the ophthalmology, both community and 3 acute hospitals, and with one of the biggest private hospitals in Ireland. So we've moved it into private sector as well to test the model. So what I'm going to talk to you about today really is what we found when we started to investigate how Lean might work with person-centered. And we used a methodology called realist evaluation, which I'm not going to bang on about, but basically it really is a way of just saying what works for whom, why does it work, in what context. So what we did was we decided to look at the intervention of Lean introduced into healthcare, and how did it work, in what context did it work or not work. And we chose as our study participants, in particular, Lean practitioners who were staff within the study sites. So the first thing we did was we did a comprehensive review of the literature in Edinburgh over a 13-month period between 2016 and 2018. And we updated this again in 2021. And we focused on Lean, Six Sigma, and process improvement. We also looked at person-centeredness, care and cultures, and patient-centeredness, which was important to include, and I'll come to that in a moment. And we looked at the combination of those keywords. I won't go into the inclusion and exclusion criteria now just because of time. But basically, we found 157 publications from 13 countries, but ultimately only 7 papers actually touched on what we were trying to get to. So it was more than the 4 I originally found, but this was a 13-month review and we found 7 papers. And we identified 3 themes relating to patients, staff, and healthcare organizations. And we decided to focus on the aspect of staff as Lean practitioners, because, and not that we weren't looking at patients, that's part of the research we're continuing, or the organization, but staff for want of a better word, are the instruments of excellent quality care. So really, they are the arbiters of care that the patients receive. And we wanted to see how staff who are lean practitioners, what was their care like, and how are they enabled to deliver it using lean, and then ask the question, was it person-centered? Was it lean? Was it both? What aspects did it touch? And where did they work together, and where was there conflict? And then when we finished our review, we went into the study sites and we spent 5 months workshopping with lean practitioners there, looking at their work and trying to understand what worked for them about lean in the context to work in their specific practice areas, whether it was a cath lab or an OR or an ER, and what didn't work, and what were the anticipated outcomes when they launched into that work. So that was another big piece of the work that we undertook as well. And then we piloted our findings in practice in the study site and in the private study site as well. So that's really what we did. And I'm just going to talk to you a bit more about the actual detail of that. So there was our realist inquiry to try and understand that. We also fed that back into the curriculum. So we teach a person-centered lean curriculum in the university. And then we applied that in practice. And we have a couple of papers out there as well on applying it across different sites that we worked in as well. So by person-centered, they talk about it's an approach to practice that establishes the formation and fostering of relationships between all care service users and others significant in their life. But it's underpinned by respect for person or personhood, individual rights to self-determination, mutual respect and understanding. And in relation to that, I suppose breaking it down, there's person-centeredness, which refers to embedded practices within a specific type of culture that enable and facilitate the delivery of what we call person-centered care. Person-centered cultures have to be in place to deliver the care. And person-centered care has an explicit focus on ensuring that everybody's included in that care, not just the customers, but the other customers. We're all customers of each other. Doctors are customers of nurses, we're customers of porters, we're customers of physios, etc. So we're all customers of each other. So it's really understanding then it's the culture piece that care will be lean, will work well in a culture that's obviously receptive to it. We then looked at a model which already existed, developed by Professor Brendan McCormick, who's now in the University of Sydney, who was in Edinburgh working with us, and basically locating service improvements such as lean in relation to person-centeredness and person-centered cultures. And basically they were saying when you start to where you want to get to. So when you start, if you have a very approach to lean that's very tick box, tool-driven, orientated, and compliance, it's about performing on compliance, you'll have aspects of what we call person-centered moments. When your service improvement starts to be embedded and it starts to thrive, then you'll have more person-centered patterns where it becomes more normal. And then as you're person-centered, you really embed and you have your lean culture developing, the lean culture then is synergistic with the person-centered at that point. You'll then start to have the innovation and the flourishing and building on new ideas and the second generation projects. So we wanted to sort of test that model as well. An important thing we found, I suppose, just to say is, I'm just putting this slide up. I'm not going to talk through it in too much detail, but we often talk about patient-centered care and person-centered care in the one breath. And really, they're two different things. So I will often hear people talking to me about how their care is person-centered, but it's only actually patient-centered care they're talking about. It's not looking at persons, the other people involved in the care. What was the impact of the improvement on staff? Did we make things better for patients by making staff work extra hours for no remuneration? Our staff were running on goodwill in those contexts I spoke about earlier, the current context in healthcare internationally. So it's understanding that person is different to patient. It encompasses patient. And Brendan McCormick, and it feels like I'm quite, but he has published over 600 articles on person-centeredness. So he is like the world expert, one of the world experts. He often talks about patient centeredness masquerading as person-centeredness. So I think it's quite interesting. And this slide will be in your own slides as well, and the references there just to have a look at. So what we found were synergies. So from our review of the literature and working with the teams on the ground, we found where is lean synergistic with person-centered approaches. And the first thing that stands out across every piece of improvement we can see is voice of the customer. It is one of the most powerful tools in our arsenal. We sort of do it without really thinking about it. But from a lean point of view, the voice of the customer is getting in there. It's talking to the people who do the work. It's talking to, I don't like the word, but frontline staff. It's engaging with the people who need to live with that change. It's engaging with the people who need to understand what's in it for them, what to get their interest, why are they going to go for this change. And that's probably the most powerful tool. So initially, when we were looking at the literature on this, I was delighted because I was going, well, there's one thing that's synergistic with lean. It's obvious, but now we have actually got empirical evidence to support it. The next one then was observational study. So in person-centered work, they carry out so much observational study. And really, when I was looking at this reading, I had just had about 30 papers to read on this. I was going, well, is that not Gemba? It seems pretty similar to me. So you start to look through it and understand that actually, more or less, it's the same. So it's very synergistic. There's that compatibility there, and we're doing it anyway. So if somebody was saying to me, well, you're not very person-centered in your work, I'd be able to say, well, actually, we are. We very much about the voice to customer. We're very much about observational studies. The next synergy that we found was obviously respect for person. I mean, you all know this. You're all lean practitioners. The three main features of Japanese management philosophy: the harmony, the loyalty, the consensus and decision making, the respect for person. It's inherent in lean. It's inherent in good change. It's inherent in Kaizen. And sometimes, I suppose, when we're busy, we sort of do lean by rote or by tick box because we just have to get it done. We sort of miss out on this piece, or we do respect for person, tick, move on, observation studies, tick. So we can make it a bit tick boxy, or a bit of I suppose, what I would like to call it is sometimes a decontextualized toolkit, when that's never how it was envisaged and that's never how it should be used. But again, in the pressure of a busy system, we sometimes just need to get it done, and we can revert to that. But it's not how it was designed. So again, I was saying we were able to say, yeah, we found another synergy here. Now, the next one obviously was staff empowerment. So person-centered cultures enable conditions that enable staff to make to engage authentically in improvement. For staff to self-select for improvement. Like, I want to be involved in that improvement, instead of being told there's an improvement happening in your department, you need to be at this. You know, that people actually want to be involved. They're there because they want to be there, as opposed to being there because they're coerced or they need to be there. And central to a role of innovation in person-centered improvement is innovation. So lean is innovative, as we know, at least innovative solutions. And we found that when you looked at lean and when you looked at the staff empowerment within the person-centered models, that they were very closely aligned. So we were sort of going, this is great, because we now know that there are proven synergies between both methodologies. We now know that there is something we can say to people when you're doing your lean work, focus on these areas. And if this is person-centered, it's synergistic, and you can work with that. Quality, we sort of agreed as a team of researchers, it straddled both lean and person-centeredness, because it works differently in both, even though they're both improvement methodologies. And this was because in person-centeredness, there's different understanding sometimes of what voice means, of looking at experience as opposed to outcomes of care. So, for example, if somebody's given a terminal diagnosis of cancer and told they have 6 months to live, they know the outcome. They know what's going to happen. It's their experiences of their care, of their life, what the end of life is like, that's more important to them. And the experiences for staff in delivering that care and how they're supported as well. And then there can be and I know Mark has spoken to this a lot as well, there can be a focus on metrics, on the outcome metrics, without an understanding of the impact it has on staff as well. So there is a potential there. So we squarely placed that. And just to say, this is ongoing research, is never ending. It's like the never ending story for those of you who've seen that movie. So this happens though when lean is used as a decontextualized toolkit, when we revert to that type of toolkit approach. But in that instance, then we would find quality to be divergent. However, we feel it's a good bridge. It's a fertile ground to link in both methodologies. In relation to divergences we found, the first divergence we found was in relation to first principles. So when we looked at the first principles, lean is about value, it's about understanding value, whereas the first principle in person-centered improvement is to assess professional competence, commitment to practice, and people's beliefs and values. So they're sort of heading in the same direction, but they have a different first principle before they start. According to Brendan McCormick, who I seem to be citing all evening, he said that person-centeredness has the attributes of a caring approach to how we meet needs, nurturing relationships, promoting social belonging, creating meaningful spaces and places, and promoting human flourishing. So you can see those principles are slightly different, although we do a lot of those things in lean and we probably call them different things. That's where you have to start with a person-centered improvement. I'll be honest with you, it does take a bit longer. However, what we've been doing over the last number of years is we have been trying to narrow the divergence between them. And what we do is we use, now that we're aware of these divergences, when we start working on projects and we start working on with teams, we start to look at the divergences as well and say, well, where can we narrow that divergence? Where can we ensure that this doesn't happen? How do we do this? Will we do, our values and visions up front? The core values, I suppose there is a divergence there within the understanding of core values. Ideally, in an ideal world, it would all be the same, but really lean, where it differs from person-centeredness, it does have value, obviously, on people's voice, but person-centeredness has more of a focus on social values, and that's the social values, wider social values. And sometimes in improvement, when we're just doing an improvement, we just don't have time to look at those wider social values issues. Some people call that, let's be honest, some people call that, the touchy-feely, the nice to have. I don't know if you use those words, touchy-feely, in America, but it's nice to have, but we haven't got time. So we're very much, that's where we're trying to bring that back in again as well. And then the last one is standardization. So I suppose, I am the biggest exponent of 5S and 6S. I love it. But I suppose sometimes when you look at case studies of where lean is applied, and it's, Mark has a very good cartoon he shows of, 5Sing people's desks, and you're sort of going, yeah, actually, you have to understand that oncology, surgery, where you can standardize certain items, and we do that very well in ORs. We standardize every anesthetic room I've ever worked in is being standardized. And it shows great improvement in relation to Tim Woods then. But you do have to allow for some divergence. So if you look at a lot of the literature, it talks about, particularly in relation to Six Sigma, it talks about removing variation. We very much, whenever I publish something, I go, remove unwanted variation, because a key lesson for me in the last 10 years has been that not all variation is bad. However, we talk about variation as being bad, but actually not all variation is bad. So I suppose a lot of this is common sense. So we've applied that model in practice. So we have looked at, this is just an example from an ophthalmology cataract pathway. So just to give you a bit of detail on this, we started off with a very disparate system in the northeast of Ireland. We had 40, which isn't not big numbers for you, but remember, Ireland only has a population of about 5.4 million. So in the northeast of Ireland, we had 44,000 patients on waiting list for cataract surgery. Now, that may not seem a lot, but the cataract surgery age, as some of you will know, is 85, in their 80s and older. And currently, the way the waiting lists were working, we could see that some of our patients would be dead before they got their appointment. This is being quite honest. So it was just completely unacceptable. So usually, we decided we would obviously use a lean approach. We then were working with the team, and we decided we would sort of step back a bit and do a person-centered lean approach and apply the person-centered model. So we spent probably the first year, and it was during COVID, just working with staff across 10 sites, 14 sites in 10 organizations in the northeast of Ireland. And what we did was we spent that first year unifying them into a VACO, which is a virtual accountable care organization. So just to say, nobody was getting a salary. These were all people who were volunteering to be part of a virtual organization. Some of you will be familiar with VACOs. And basically, We spent that first year understanding what staff valued in the service, what they wanted from the service, what they wanted for the patients. This is before we went near any patients. And the four things that came up for us were 4Ps, place. So they needed a place that they could do their work, that had natural daylight, that wasn't a storeroom. Procurement, so they had the equipment to do their job. People, that they had the skill mix and the staff to do the job. And then the last thing was patient. Not that the patient came last, but they needed these prerequisites in place to deliver that care. And then trying to understand that before we went further than that. So then the team on the group went together, and it became the Northeast Regional Integrated Eye Care Scheme. They brought this to the Irish Parliament. I'm not sure if you call it the Parliament in America, but they brought it to the Irish Parliament. They presented their case for funding. They were able to get funding to support this work at a government level. And this is just one of the pathways. So they started with 5 pathways: cataract, eye emergency, glaucoma, pediatric amblyopia, and acute macular degeneration. And applying this model, working with patients and staff, you can see here that their right first-time referrals were 95% post-intervention. Their optometrist first referrals were 80%. Their conversion rate to surgery was 95%. GPs, the general practitioners in the community, got 51 days returned in 2022. Very much increased patient and staff satisfaction. There was a decreased travel time for patients. So before this intervention, patients could attend the acute centre up to 4 times. Now it was 1 stop. And then the time to surgery was reduced by greater than 50%. So we know that the model works. It takes a bit longer, I suppose, and there's a bit more groundwork to do, but we could see that it worked within this setting. So that was across those sites, and that was multi-site, again, 10 sites, or it's 14 centres, 10 sites. But again, the model worked very effectively there. This is a case study of a hospital, pediatric hospital, where a child spent about 5 hours traveling from Kerry in Ireland. Some of you have heard of Kerry, the Ring of Kerry, to Dublin. 5 hours from the more rural Kerry to Dublin. But that doesn't seem a long time. I know for Americans, you drive everywhere, but for Irish people, an hour is a long drive. We're a small country. So 5 hours to Dublin, 4 hours in the waiting room, and 10 minutes with the clinician, the cardiologist. So 9-hour wait for 10. And they wrote a paper to the national newspapers. They wrote to the CEO of the hospital. And like a lot of things with lean, it became a problem because it was solved because attention was drawn to it. So this was very much a poka-yoke, where you found out after everything went wrong as opposed to predictive. What was interesting on this was this was a very busy cardiology service with multiple cardiologists and clinics, and really the hospital we were working with, although they had a very good team, they were so busy that they really didn't have a lot of time to do gambas. And though they had black belts and they could pull on those and some green belts to do gambas, they didn't have enough. So the more person-centered approach was, we met with the parents and we said, look, this is what we're trying to do. We really want to make these clinics work for you. There's a huge problem. Would you do observational studies for us? So we got, fortunately, 90 families volunteered to do their own gambas and collect their own gamba data and basically record their clinic journeys for us. And then work with that with the staff and explain to us. And some of the questions that came up really were patients going, why does my child have an ECG every time and an echo? And when we actually did a 5 in it, we were able to go, well, they need an ECG, but actually they don't need an echo, but we've always done it this way. So maybe if every child didn't have a routine echocardiogram, then this would look slightly different. So they started to restructure that. So basically, you can see here the value add time this was the clinic. This was the value add time pre. This was the non-value add time pre, which far outstripped it. And then the value add time post and the non-value add time post. But you can see here, the main thing is that the clinic duration completely came down. So the clinic used to start at 8 a.m. It was meant to finish at 1 a.m., an hour for lunch and setup of the next clinic. And then the next clinic, when it started, would run into the evening. But what was happening was the clinic overran. So you had a very overcrowded waiting room with kids and parents waiting, and staff didn't get their lunch break. There was no time to set up the next clinic. So there's a complete overlap. So they took this improvement and the model that they had come up with, and they used that model to structure that for their new build. For the new build of the most expensive children's hospital in the world will be opening in 2025 in Ireland. It is the most expensive children's hospital in the world, just to say. That is not a lie. And then, so this again was applying that model, but going back to patients and asking them to do Gemba. Again, the more took longer to work with them to understand what that was, but they gave us very rich data, which enabled the change. Applied in practice to cardiology remote monitoring clinic. This was a clinic where they kept having lots of unscheduled attendances. They were trying to get up their remote monitoring numbers. They couldn't get the remote monitoring numbers up. So what they did was nurses would talk to the patients, doctors would talk to them. They would do workshops. There would be patient advocates talking. So again, we took time to talk to the team who were working at Paul and the team. They took time to talk to the patients who are already on remote monitoring, and then they removed themselves. So they asked the patients who are already on remote monitoring to deliver why you should choose remote monitoring as an option. And at baseline, they did that, very kindly became, part of the lean improvement. The patients became part of the improvement team. The clinic was processing 102 remote monitoring follow-up checks with 140 unscheduled attendances, which meant the clinics were just overrunning. Following implementation, they had a 194% increase. They were looking for 50% increase with 41 unscheduled attendances on average per month. So there was a 72% or 70% decrease. And they were still sustained, and they're still sustained today post-implementation. So basically, it really just changed the way the service works. Again, the model applied. It's lean. It's still lean. It's just slightly. It's just that we go through the person-centered piece as well, and just check we're applying that lens as well. So it's like applying two lenses: a lean and a combined person-centered lens. And then I suppose another case study would be we used the model post-COVID. We wanted to reboot services in that private hospital I was talking about, one of the study sites. And the goals that they said for rebooting the service June 2020. So just to say, private hospitals were co-opted by public hospitals during COVID, but as COVID started to tail off in the first wave, private hospitals returned to function. So basically, you can see they met all their targets, including a zero transmission rate for COVID, and this was in 2020 pre-vaccine. So you can see that again, by taking the time to structure our rapid improvement events with a combined person-centered lens and lean, we had very good results. You might say, what would happen if you just did lean? We would say it would probably work. But we have shown through the work we've been carrying out in the last 3 years in particular, the sustainability of the results because of staff involvement, staff buy-in, patient involvement, but also the fact that we're looking at those points of what people value in more detail. Lean does this. I'm not saying it doesn't. I'm a lean practitioner, but what it's doing is it's emphasizing what lean does well, and it's asking us just to consider the person-centered piece in it when we do it. And I suppose finally I have time for one quick case study. Applied in practice, a hip fracture, again applying the model here. The Irish hip fracture database recommends, this probably is shocking to some of you, that patients get to theatre within 48 hours if they have a hip fracture. That's considered good. Within 48 hours, they've less decompensation. And this team were working together, were able to get this down to 48 hours. But interestingly, what happened on this case was they were only looking at time. But when they stepped back, and that was the only metric they had to improve, it was in line with the Irish hip fracture database. When the team were looking at this, they noticed that patients in the ER were getting analgesia, but weren't getting the optimal analgesia, which was a local block into the joint, anesthetic into the joint. And what they found was that these only happened in the OR because the anaesthetists were too busy to come to the ER to deliver these. So patients could be waiting 40 hours before they had the analgesia of choice. They still had opioids, but not the analgesia of choice. So what they did was, and patients had given feedback, and the staff looked at this and they said, look, from a point of view of customers weren't asking for this because they feel they're getting pain relief, but we have to look at this. They were able, the non-intended target, they were able to redesign the system, and the advanced nurse practitioners and the orthogeriatricians trained to deliver the block in the ER. So they went from pre-intervention, 8% of people receiving the optimal analgesia in the ER to 88% 3 months post-intervention. So again, it's a project that builds on that type of change. I'm aware of the time, so I've just put up a reference list. Most of those are in publication if you're interested to read them, and I will be very happy to take any questions.
Thank you, Sean Paul. We'll leave your contact info up there for a minute, and then during the Q&A slide, your email, Sean Paul's email address will be there as well. So I'll encourage people, please continue submitting questions. We'll be able to have a good opportunity to discuss those, so keep those coming in. A few announcements before we get into the Q&A, if you can advance the slide, please. Oh, and tell us, I'm sorry, what it says under the thank you. Could you say that for us?
I'll go with me the Mahagut. Yeah, that's Irish for thank you. Gurav Mila Mahagut. A million thanks. Thousand thanks.
I will just say a hearty thank you in response because I don't speak Gaelic. So thank you for that. And thank you for the presentation and thought-provoking material that you shared. So if you can advance the slide, please. A couple announcements. You can get notified about future webinars by going to kainexus.com/webinars. Look for a link there to sign up to get notifications. I'm still trying to finalize details. So everyone who registered today will actually get emails automatically about the future webinars. August 24th, Arno Aurelio, who will be joining us from the Netherlands. I guess it's Europe month on the webinar series here. August 24th, Lean Thinking in Healthcare. That's the title of his new book. And again, I would encourage people, please come and attend regardless of your industry, because to some extent, lean thinking is lean thinking. We can learn from each other across industries as we're doing today. You can also find our KaiNexus webinars on demand library. I never have the exact count. It's more than 100 recorded webinars from the past years that you can go and find there. Click on the webinars on demand library button at kainexus.com/webinars. Next slide, please.
Yep. Sorry.
We invite you to visit our blog at blog.kainexus.com. There's a couple of great posts there every week focused on different continuous improvement methodologies and different industries, or again, the ideas that kind of go across all industries. Next, please. Also invite you to check out our podcast. It's available through Apple Podcasts, Google Podcasts, Spotify, Overcast, wherever you might listen to podcasts. The audio of today's webinar will be there in the podcast feed if you want to go back and revisit this and listen again on your way home from work someday. And we hope you'll subscribe to that podcast series. Okay, if you can advance it once more. Okay, there's Sean Paul's email address. So we've got a question first off here from Michael. How does person-centered improvement compare or contrast with what some people call human-centered design or design thinking?
Yeah, thanks, Mike, for that question. I suppose, well, first of all, just to say, I'm very lucky. I work with a team, and clinically, I work half-time in university, half-time clinically. I work with a team of in an office called Transformation Office. We work with a lot of designers from the National College of Art and Design, and they would use like human-centered design, and they are quite synergistic. And I would work on projects with them, clinically based projects with them. So it's focusing on the user. The human-centered design is often designing, as you'll know, a product or an output. A lot of our designers work on I'm just thinking of a project we just worked on with a dermatology service where they designed skin graft models for GPs to save patients coming into hospital for diagnosis. They can be diagnosed better in the GPs because they have these models. But actually, they are quite synergistic. Person-centeredness, though, goes back to the work, I suppose, of Tom Kitwood, which was developed initially from dementia care. And that goes back again to the concepts of, people's dignity, personhood as well. So they are similar. I would argue that person-centered approaches are as holistic, but they are more focused on those values and beliefs. And I suppose the softer bits. Not that human-centered design isn't, but certainly from the human-centered designers I would work with now, in the transformation from National College of Art and Design. I would see that as being a slight difference there. But again, I would use them. Again, to be honest with you, I work on a team that uses whatever methodology we need to use. Sure. for whatever the problem that presents. It's not a square peg round hole, I suppose.
Okay. Well, thank you, Sean Paul. There's another question here. What should be the culture of the organization and its employees to be able to apply the person-centered improvement model? In other words, is it possible to apply the model in all environments, regardless of the culture? Maybe I'll just add on to the question. It sounds like a chicken and egg situation. Do you need the right culture to do these things, or does doing these things help build the culture, or both?
Yeah, good. Thank you for that question. That's really good. So I suppose any transformation journey, they say, takes 2 to 10 years. Certainly in the hospital I work in, and Mark has visited that, when it's just celebrating 10 years of its lean program now. And I say it was about year 4 before we started to have what I would call a lean culture. And how I know that is, there's architects who work with me on my team who went to work in the UK and the NHS and came back. And when they came back, they said, there's been a shift in the culture. They were saying that to me. And I was going, is there? I don't see it, because I'm just trying to get the work done. So that was one thing. But then, having said that, the private hospital, where we work, they have within 5 years established, and Mark actually has visited there as well, they've established a lean culture in about 5 years. So I would say it's context driven. To quote some of you know Barry Oshley's work, it's context. I think it's contextual. I personally, I think that you can, if people have done no lean at all and you're trying to introduce a model, you could introduce lean with the person-centered lens. If lean's already there, obviously you could introduce the person-centered lens. In fact, it's nearly more difficult, if I'm honest, to go into organizations that are using person-centered approaches and try and introduce lean to that, because you get the usual, it's from industry, it's not person-centered, we've done that before, oh no, that doesn't work. So actually, it's nearly conversely, in my experience, particularly in working in units that were doing dementia care around Ireland, which were using person-centered approaches, it was more difficult to introduce lean on top of person-centered than person-centered on top of lean, if I'm honest. Mm-hmm. Because I think once you're a lean practitioner, you automatically go for the voice to customer. You automatically, are doing Gemba. So you're nearly open, and you're more open to change. It's actually harder, I would say, the other way, if I'm honest.
Yeah. And we've got a follow-up question, maybe kind of building on part of that. Michael McFadden asks, how might we overcome resistance to lean language and methodology due to prior negative experiences and misconceptions? And I'll just add on a comment. I think what you touched on earlier, Sean Paul, about you look in the literature. I've seen a lot of articles published that really do paint this negative picture of lean. One example that comes to mind is, engineering graduate students following doctors and nurses into the bathroom and timing how long they were in there. And I hate reading about that. And I said, well, I don't think that really sounds like lean, but some organizations are doing that, and then it gets published and there's a yikes in the comments. So anyway, let me stop with my editorial comment and turn the question back to you, Sean Paul. Trying to overcome some of the negative experiences that people might have had or even read about.
Yeah, I think that's a really really important question. So when we start off with our, I suppose, introduction to process improvement, like our 1 day type of foot in the water, we've over like 5,000 staff, people have completed that. And what I always say to them on that is, healthcare is already full of jargon, like total hip replacement, THR, open reduction, turn flexion, ORIF, all those type of things, transplant TX. So we said we're not going to use any jargon today. We're delivering this in a way that means something to you. But one thing I would find, I'll be honest with you, is I've seen people who've done, some of you maybe here from the UK, who've done what it's called the Productive Ward series, which basically is like 5S, a program developed by 5S, by the National Health Service in the UK. And they say, oh no, we've done lean and it didn't work. And I was going, what have you done? And they say, well, we've done the productive. I was going, well, no, that's not lean. That's an aspect of lean. That's just the 5S. So actually, you haven't tried it. Come here and I'll show you. No, that sounds very Irish. Come here and I'll show you. Come here and I'll show you. And I'll come over here and I'll show you what I'm talking about. And actually just sitting down and talking with them. But I would agree with you. It can be very jingoistic. And I'll be honest, hands up. I remember when I was a manager in an OR running 12 ORs, and my staff were going off to lean training. I was going, where are they going? Oh, they're going to lean training. I was going, what's that? I don't care what it is. I need them on the floor. So I was actually the anti-lean for a period of my life. I was going, no, I need bodies on the floor. I don't need them off doing this lean stuff, whatever it is. So, this is before my exposure. So, I would agree there can be negativity there.
It sounds like you were anti-taking my people away from the unit.
I was, yes.
For any good reason. But yeah, it's interesting, thinking back to the NHS program, the productive ward, at one point that methodology was renamed and relabeled as releasing time to care.
Right, yeah.
And I heard at least some commentary from people that the phrase the productive ward sounded a bit blaming of like, well, what do you mean we're not productive? Whereas releasing time to care is this really important goal that maybe it's easier to rally people around.
Yeah, but actually, Mark, interestingly on that, I worked on we published a paper there last year about streamlining OR efficiency. And when we were talking about releasing time to care, the nurses who were involved in all of the OR nurses were going, how about releasing time so we can get our lunch? It's not just about the time doesn't need to be released for caring for patients. We actually need time to care for ourselves. And actually that's really important as well. And I think that's where the person-centered piece comes in. You're going, actually, it's not just about more productivity, it's about enabling staff to actually recharge their batteries. But that came from the staff themselves.
Yeah. And Toyota teaches that it goes hand in hand, caring for focusing on the customers and caring for the employees, and it goes hand in hand. I think that's especially true in healthcare. But I was going to ask you back to this question of like, hey, we need lunch, we need releasing time to care for ourselves. How do you help make sure when we're looking for the voice of the customer or the voice of the staff member, that we're not assuming we know what they need, and that we're really, really asking and really hearing what they say they need?
Yeah, that's a really good question. I say that for all the questions, very good. Well, it's basically just taking the time to go and talk. And so, like, we would do a lot of initial surveys, but then we might do focus groups. Then we may go ahead and do more one-to-one qualitative interviews. I personally, when I'm working with teams, I like to talk to people individually because, as you know, you can put people in a room, but it's very hard for people to express what they feel when there are managers in the room with them. We talk about, there are those things like we're all here together and everything's fine, but so we would talk to people depending on what the context is again, but ensuring that their voice is heard. And then I suppose an important thing is as well recognizing that if people don't want to involve, then that you shouldn't coerce them to involve either. Going back to that, one of the big things I found in my own research is, and I'm sure you all know this, improvement works better when people self-select as opposed to being told you're doing improvement. So if people want to involve and are genuinely interested, then you're obviously going to have a bigger bang for your buck, and it's more sustainable. So certainly we'd spend a lot of time. In fact, I would say on most projects, and I'm sure a lot of you have seen this, we'd spend about 40% of the time on a project just getting a sense of get 40% just talking to people, and before we even start, because otherwise we're sort of symptom solving rather than actually root cause analysis. So yeah.
Another question here, Joaquin asked, what recommendations do you have on how to anchor or calibrate a team, and most importantly, the leadership team, on what respect means and how it looks in practice? What challenges have you observed when a clear understanding of respect for the person is not achieved?
Yeah, I say it again. These are great.
So it is a good question.
Yeah, it is. It is a good question.
Yeah.
I think first of all, I have a PhD student currently looking at lean leadership and what are the attributes of lean leaders, and in her research, this is why there's a whole research question in that. But certainly, there's what I found in my own research is my own PhD. There's leadership, and then there's visible leadership, like the management by walking around, the leaders who go to Gemba. I think that there can be what is most off-putting to staff and to lean practitioners is where there's token. I'll give you an example of a CEO turning up to a report out from a lean initiative and standing at the back of the room on their mobile phone or their cell phone, as you guys call it, the whole time. So actually, I prefer if you weren't there, because that's not respectful. And then to afterwards take them aside and respectfully say to them, that really was noticed today. People, I think that's your role as an improvement facilitator, is to take and say, look, that really, that's not actually what we need. That's not what we need. And people noticed, because when that particular report out was over, that the effect that had on staff morale was palpable. People were furious. If I'm being honest, people were very, very annoyed. And it took a lot of work to bring them back to a point of we can move forward from here, because they just felt their improvement work wasn't valued. Now, in fairness, contextually, the CEO was probably under pressure to be there that day. But I think if you're going to be there, be there. And be. But yes, I think it is a challenge. Again, it's contextual. Give that. And again, I could give an example. I've worked in public hospitals where the CEOs will be there, and they may just do the tokenistic thing. And I've worked in private hospitals where I think the last time Mark was over, he was at a hospital with me in Ireland where the CEO goes to everything lean. He turns up, he makes sure he's there, he offers comment, he supports the staff, and you can see the difference in those people. So I think they're in lean deployment, and that's why there's an entire PhD taking place in it now. My colleague Anne-Marie, one of our PhD students, she's looking at that. What are the attributes of lean leadership? And one of them is, the concept of respect, obviously, and how do we instill that in leaders?
Yeah. Thank you, Jean-Paul. It's well said. And we have time for one more very good question. Even if we run a minute over or something, maybe that's okay. Does lean examine communication mechanisms to ensure they're evaluated and responsive, to ensure that they're safe and support inclusion, diversity, equity, and accessibility?
Thank you for that question. So I would say that in the first 100 projects I was involved in, when we did an audit of them, 80% of the problems actually were down to communication. And they were either communication of miscommunication, untimely, late communication, as timeliness of communication, and the last thing was no communication at all. So communication was a huge thing. I think that's where the person-centered piece can come in relation to communication, because I think you mentioned there some important things like gender and ethnicity, and minorities as well, that everybody is represented and that everybody has a voice at the table completely. So I think it's more, so I think that's where the person-centered lens, I mean, I call these lenses lean. You can say, look at things through a lean lens. It's not that you have to change your lean work. Lean, I personally believe, I always thought that lean was synergistic with person-centeredness, but there was no empirical evidence. So I made it my business to go out after reading that paper, as Mark said, you read something saying, oh, lean is not person-centered. And I was going, well, I don't believe that. I want to go and prove my point. So I think it's just an added lens that you add on. So it's a bit like having a pair of, what you call the pair of glasses with a pair of glasses over. You just have a slightly different view of the improvement.
Well, thank you for helping make that case today, Jean-Paul. Really appreciate you doing the presentation. Really want to thank everybody for attending and for asking so many great questions. So it's been a real treat. Thank you. Thank you again, Sean Paul. Is there anything final comment that you'd like to make before we sign off?
No, I'd just like to say thanks to everybody for coming. I really appreciate that. Just to say, we will be formally launching the model actually in a booklet, like a form. One of our designers is working on it at the moment with various resources as well. We're formally launching that in November in Dublin at a conference. Hopefully our Minister for Health will launch it. So if anybody would like to use that model, just feel free to use it. I mean, it's easy to use. So if you want to use that, give me a shout. I'm very happy to share it with you. And we can share anything we're doing on it as well. But we're just trying to get that out there. So if anybody's interested, you're more than welcome to use it.
All right. Well, thank you again, Sean Paul. There's a lot of thank yous in the chat, so I know people really appreciate this, and I'll encourage people, please do fill out the survey that you'll get brought up on screen or sent to you via email. And we do like to hear from people. What other topics would you like to hear webinars presented on in our series? So on behalf of the whole team at KaiNexus, I want to thank everyone for attending. And again, Sean Paul, thank you for being our presenter today.
Thanks very much, Mark. Appreciate that.